right, I am Dr. Rania Rifaey. I'm an interventional pain physician at Comprehensive Orthopaedics in Wallingford.
And I'm Sam. I'm one of the physical therapists on staff here at Physical Therapy and Sports Medicine Centers here at Southington.
And today we're giving a joint talk on interventional pain management and physical therapy. So for our agenda, we'll be talking about when physical therapy is indicated in the treatment of painful conditions, what the evidence for that is, and we'll focus a little more on lower back pain. And then Sam is going to talk about physical therapy and the specific modalities. So in terms of when patients should be referred, it's really first line pretty much for any musculoskeletal complaint, in my opinion. Patients have to want to go. There's autonomy in medicine, so if there's a patient that doesn't want to go or expresses reluctance about going to physical therapy, I think it's my job as a physician to delve into why. Perhaps they've had an ineffective experience in the past, perhaps they had a suboptimal experience where it was just, ice and heat and no active exercises that were being used. Or perhaps they've never been to physical therapy, but they're basing this opinion on their neighbor's experience which was terrible. And then the pain has to be somewhat controlled. Patients who have severe pain are not going to thrive in physical therapy. You've probably had that experience before. So sometimes we'll do a cortisone shot or a trial of medications, and once the pain is controlled, have them go to physical therapy then at that point. And then, as I kind of alluded to, there's passive physical therapy, which can include things like ice and heat and manual manipulation. And then as another broader category, there's active physical therapy, which includes exercises. And I really think that this is the most important part of physical therapy. And it's so critical, the education that you guys provide, because it really empowers our patients to kind of manage their pain in the future should it occur again. So I have an example of how it can spiral out of control. So let's say a patient has greater trochanteric pain, so pain in the side of the hip. That's often due to weak hip abductors. So those are the muscles that raise your leg out to the side. So this goes on for a while, and eventually they have an altered gait, and this can predispose that patient to the development of knee arthritis. So this could have all been prevented if we just focused on the initial problem, which was weak hip abductors. So this was a study that looked at 169 participants, and they were randomly divided into a physical therapy arm and a decompressive surgery arm. All of these patients had spinal stenosis. So 74 patients in the decompressive surgery group went on to have surgery, and at 2 years out, 61% of them had relief. 44 patients within the second group actually switched into the surgical group. So of the remaining 29 patients in the physical therapy arm, 52% had relief at 2 years out. So 52% versus 55%, not a huge difference. It was really interesting though, of all the eligible participants, only 65% decided to participate because they didn't want to risk being in the physical therapy arm. They wanted to, the preference was to get surgery. And I think that's something that, kind of speaks to our society a little bit in terms of, this quick fix. It's across the board. We all want this. We are busy and we want something quick that's just going to fix it. So lower back pain, in terms of the epidemiology, it's a leading cause of disability in the United States and globally. The lifetime incidence is between 50 to 80%. There's no evidence to support prolonged bed rest or bed rest longer than 4 days. And it's been shown numerous times that reduced strength, flexibility, and endurance all contribute to the development of lower back pain. So typically, the most common cause of lower back pain are what we call strains and sprains, which are just injuries of the muscles and the ligaments. It typically presents as pain that increases with prolonged sitting, bending, standing, flexing, and extending. The patients describe it as kind of a deep and dull ache. Sometimes it's associated with what we describe as muscle spasms. We don't recommend that imaging be obtained in the first 4 to 6 weeks in the absence of trauma or red flag symptoms. And when we talk about red flag symptoms, we mean things that point to infection or malignancy or fracture. So things like unexplained weight loss, fevers, chills, night sweats, loss of bladder and bowel function, a patient who's been immunosuppressed because they're taking chronic steroids, is more likely to have infection. A patient with a history of IV drug abuse is more likely to have an infection or an abscess. And then, any patient with a history of cancer, you have to worry about a recurrence of their cancer. And then in terms of, the algorithm for how we treat lower back pain, it's not necessarily a stepwise A, B, C, this is the order I go in. It's usually, throwing lots of these things at the same time at the problem. So physical therapy in conjunction with steroid injections or radiofrequency ablation procedures with anti-inflammatory medications, all of these things go hand in hand.
And then just to kind of give you an overview of physical therapy, especially if you've never been to PT before, I think there's kind of this, okay, what am I going to experience? So I want to give you an idea. Initially, just like you would go to the doctor, we're going to do an evaluation on your first day, really get an idea of what's been going on, how did the problem start up, where are you at with it at this point, what kind of things contributed to it, really understanding your history behind that. And then we're going to go into a more functional evaluation. So I'm going to take a look at your overall movement, how are you doing with bending, twisting, reaching, things like that. And then really start to break it down. Okay, why are you moving in a way that's painful or dysfunctional? Is it because of lack of strength, range of motion, flexibility, whatever it might be? And then we're going to figure out how to take all those deficits and create a treatment program that's going to be individualized to you as the patient. And gradually increase the difficulty of it as you can kind of tolerate to get you back up to that really high level of function again. So really those treatment strategies are ideally aimed at essentially improving your function and decreasing pain. And those two snowball on each other over time. As you get more and more functional, you're going to have less pain. If you have less pain, you're going to get more and more functional. So. And there's kind of two aspects of PT. There's the real long-term aspect of things where we're taking those weak areas and we're strengthening them, and it takes a few weeks to develop that strength and get stronger. It's not an instantaneous thing. And really starting to stretch out or start to mobilize some of those tighter, restricted areas in order to get to that optimal level of function. And those are the things that are going to keep you healthy in the long term and that you're going to continue to work on even after you leave here to be healthy. And then really just like Dr. Rifaey had mentioned before, patient education is huge on this. So patients that really understand their condition and what's going on with their bodies tend to do a lot better than those that are just kind of left in the dark and haven't quite grasped the concept of what's going on. So we really try to help people understand their condition and really what to expect in the process, how long this is going to take in terms of getting relief and understanding, especially early on where your tissue is just so irritable, the difference between just pain and soreness. So, it's okay to have a little extra pain with some of the exercises, a little extra discomfort, but we want them to be generally pretty comfortable for you in order to get better and better that way. So, and then, again, coordinating with the healthcare team as a whole. If something's not looking quite right and maybe we're making some good progress initially, then we plateau it all, then we coordinate right back with your doctors to make sure that we keep everything moving and we don't have too much lag time or anything. So that's really important. And then, more of the short-term interventions, just like she had mentioned some of those passive modalities before, those are really aimed at decreasing your pain in the short term, kind of controlling some of the inflammation, increasing blood flow in order to help you deal with the pain shorter term. So things like heat, ice, ultrasound, E-stim's probably a pretty big one too, that are all aimed at dealing with those factors. The traction and the pool, a little more specific to certain conditions. We don't use those, probably as frequently, but those modalities definitely help us to alleviate some of the pain so that you can start moving better and better. But in isolation, they need to be with conjunction to those exercises, not in isolation. And then the manual therapy is almost an intermediate, so doing some of the different massage techniques that we do, some different stretching with you, even joint mobilization and manipulation if it's appropriate in that patient's case, where we start to push into the joint just to make sure everything's starting to glide better and better as you go in order to move in those functional patterns again. These are just some of the commonly treated spinal conditions I just have here listed. between sprains, strains, herniated discs, disc degeneration, stenosis, radiculopathy, etc. And those are things that you're going to see on the script, and your doctor will explain to you, and we'll explain to you again kind of what's going on behind those things. So just know that this is just a couple of things that we treat specific to the spine, and there's obviously more out there that we take a look at too. And then just to kind of understand where we might go with some of the treatment, like I had mentioned, strengthening and stretching, but you tend to, especially with the spine, start to fall into just some of these general categories. And they're kind of logical when you think about them. You have someone who maybe has some excessive movement at some of the joints, is very hypermobile. We're probably going to start to orient some of our treatment to be more core stabilization, where we're doing some different abdominal strengthening, hip strengthening, to help you hold that posture as you're starting to move through different things, lifting and all that, as opposed to maybe a more mobilization and manipulation category where you're just really tense, really tight, things just aren't gliding quite right between those joints, that we need to kind of open those up to allow them to move a little bit more. And then another category, more positional preference, and this is kind of nice too, that some people, they go into a little bit of that flexion or extension, and they can notice some immediate relief actually, and we use that to our advantage early on when things are just so irritable, that we can start to work some of the strength and everything in those specific positions to help alleviate some of the pain, both short-term and long-term. And then a different variation of that, traction and decompression, we would either do mechanically with a machine or by hand. A lot of times I kind of test it out by hand, so you can kind of interact with me and understand, okay, how hard am I kind of pulling to open up those joints, and it's an automatic feedback that you tell me if something's just not quite right, or you want to do something different. Is fine that way, but a lot of patients get some good relief out of that, so we can orient our treatment with some of that. But usually there's kind of a combination that goes on with every patient. Like I said, that first day evaluation, we really get an idea for your individual strengths and weaknesses, and there's going to be some overlap between almost all these categories, but you tend to fall towards one or another to a degree. So it's not a cookie cutter treatment. We kind of blend everything together for you, the individual. And then we'll kind of think about some questions that patients commonly have here.
So one question that patients often ask me is, how is physical therapy prior to surgery different than after the surgery?
Yeah, prior to surgery, we're taking that conservative approach initially, and we're building on it, and a lot of times we do get some pretty good relief initially with things, but there are some cases where there needs to be something a little more invasive. And when you come back from doing that surgery to work with us, we have to connect with the doc and understand that there's going to be some other restrictions that we have to consider. Maybe the doctor writes the script to say, okay, I don't want to do any extension initially if it's something spine related, just because we need some additional time for that hardware to kind of heal into the body. So we're going to really pay attention to some of that to make sure that the surgery is secure. We would probably work around it a little more. For example, like a fusion, we might do a little more hip mobilization and hip strengthening, maybe just some real light core activity, but not go into some of the things that would put more stress on that hardware initially. So little different tactics depending on if it's pre or post-surgical.
Makes sense. Yeah.
And then a question for you, a lot of people say, okay, why can't I just be a shot and be done with it? Why do I need to do PT?
Right, because we're always looking for that quick fix, which I completely relate to. We're busy and we just want to get better. But steroid injection by itself doesn't alleviate, maybe it alleviates the pain, but it doesn't fix the problem. So we need to kind of look at the underlying cause, whether that's weakness or lack of flexibility, and we need to treat that at the same time.
Yeah. Another common question is, what's the worst management for pain?
The worst management by far is, a patient who's been prescribed opioids for, a decade and nothing else. Never had a trial of physical therapy, never had a trial of injections, and now, they're on high-dose opioids, and they've developed opioid-induced hyperalgesia, which is this paradoxical increase to, even the lightest touch, it hurts when you have opioid-induced hyperalgesia. So that is, by far the worst management of pain, just to be on opioids for decades and decades and nothing else. Question for you, how often should patients do their exercises?
So for the most part, we tend to tell patients to do them every day. Again, I'm not going to give you a huge laundry list initially. It's going to be 4 or 5 exercises that are really designed at some of the primary deficits that you have. So it's a relatively short routine that you can do every day without having too much of a crunch on your time.
That's great.
And then commonly we start thinking about injections if it needs to be that way. I hear, okay, is that injection going to hurt?
Yeah, I think there's a lot of apprehension that patients have about getting injections, and it's scary, especially if you've never had it done before. But generally, I have patients who say my worry, my fear, whatever kept me up at night worrying about this the next day was way worse than the actual injection. I numb up the skin with a very tiny needle, and injections are quick and relatively painless.
And then also for you, a lot of times we get, how long is that relief going to last from the injection?
Yeah, so that's a great question. It really varies. When we're talking about a steroid, we want at least 3 months duration out of it. That's the goal. If we need to do a steroid injection every 3 months, that's fine. But if it's the kind of thing where it only helped for a day, that's probably not the right thing to do again. Yeah.
And then hand in hand with that, can I do some of the PT exercises after doing the injection?
Yes, I always encourage my patients to resume physical therapy right away, unless it's something more advanced, like, I just put a spinal cord stimulator in and we don't want the patients to move and have the electrodes migrate. But no, I think what you do and what I do go hand in hand, and they need to go at the same time. And patients often ask me, how is physical therapy going to help?
Yeah, and just like you alluded to earlier on in the presentation about the hip example there, it's sometimes the biomechanics of how you're moving that put stress on different areas, that when we address those strength and flexibility deficits, that you start to see the pain and function come around, and that's what PT is really aimed at.
I completely agree. Yeah. And patients often wonder, how long does it take for physical therapy to have an impact?
Yeah, and a lot of that again is very individualized. I think about an example of, say, a soccer player who strains their back, and someone relatively young, it's a lot quicker, maybe 3 weeks before you're pretty functional and getting back out on the field and having no issue, versus, someone that's maybe a little older and, has a chronic history of back pain, that it might take a few weeks, a couple months to have things get to that higher level again. But I always reiterate to patients that, it's not going to be that same level of pain the whole time. You're going to see different markers along the way over those couple weeks of getting better and better. So it's not going to be that same high level of pain. Pain's going to come down and things are going to get better in terms of how you're moving. So it's not going to take that entire time before you get any better. It's going to be gradual. So.
I'm so glad you said that, because I often hear patients complain that, the physical therapy just made things worse. But I think that's with anything in life. As your body is repairing and healing, you may transiently have bumps in your pain, and it doesn't necessarily mean that anything's wrong. It could just be part of the healing process.
Yeah, and
as you build muscle,
Yeah, and that goes back to kind of our education, is constantly reiterating to patients that it's okay to have a little extra soreness with some of this stuff. Your body, just like if you went to the gym for the first time, you'd be pretty sore after doing it, but we have tissue irritability on top of it. So you are going to have some fluctuations along the way. It might be 2 steps forward, 1 step back, but you take more and more steps forward and you get the overall gains over time.
Absolutely. All right, I think that's all I have. Any
That's
other questions, Sam? All right, well, thank you so much for your attention, and hopefully, we don't need to see you, but we'd be happy to.
Yeah.